Hey, good morning. Zach and Hint Health and the Hint Health team, thank you for putting on such a great conference and for having me. This has been a pretty awesome experience. Even before it started, I got here yesterday afternoon. I was sitting in the hotel area and we were just having all this discussion until 9 or 10 o'clock at night. DPC owners walking in. I met people from Kentucky, Tennessee, Florida, Nebraska, and different places. Love that. So if we get a chance just in the next couple of days, I'd love to meet you. I know about 90% of the DPC owners in Wisconsin and love to meet folks from across the country now. So I am from Wisconsin, and I'm not sure what you think of when I say that, probably cold. But it's an interesting state. I'm originally a farm boy from Iowa, so I've got a very practical sense about me. And I've been in Wisconsin 17 years, but I always joke and say I'm unsophisticated, but I'm unsophisticated on purpose. I'm not here to impress you with some fancy slides. I just want to kind of move the needle, help people is kind of my root passion. So Wisconsin is an interesting state. We're number one in cheese, so that's why we're called the cheeseheads. You can see I actually made an emoji, cheesehead. I can tell you're probably not impressed. I was pretty proud of that. Maybe I should copyright that or something. But we're number 2 in dairy. We are number 10 in manufacturing, although per capita we're number 1 in manufacturing. We are number 1 in drinking. So 12 of the 15 cities are Wisconsin. And we're also like the 4th, according to the most recent RAND study, we're the 4th worst in cost of healthcare. So which makes the problem solving even that much more impactful. And I've been traveling around. I'll tell you my story, which is really interesting. But we have Inovia Health here today. We're at Ken and Sabina. So the largest DPC, they've been growing fast, about 3 years. And in Wisconsin, 8 clinics and going to be a 9th soon, 15,000 members. So great job. We'll talk about that. I met someone from North Dakota last night, Allie and Christine. Are you here? What we think is the only DPC in the whole state. Congratulations. Cool. So love that stuff. So I find myself on an unexpected path that I had a pretty somewhat normal HR career. I was always maybe a different kind of HR person. I actually drove change. A lot of HR people kind of seem to be change resistant. But I always wanted to help people and solve problems, but I did that for almost 25 years in manufacturing. So I have an employer lens I probably will carry with me the rest of my life. But the last role I had in HR was with a company called Merrill Steel in Wisconsin, and I was the VP of HR. I took that role in 2016, and almost immediately the owners came up to me and said, the last 5 years we've had 9 or 10% increase. We're already self-funded, but we've been absorbing this, but we don't want to pass this on to our employees. And so what can we do? And I said, well, I know the game. I figured out I knew the game insurance had handed us. I knew deductibles and networks and so forth. And I studied that, and I realized there's very little books and written materials and so forth. And I came to the conclusion that there's no way to win with the current healthcare industrial complex. So I knew I was going to have to get out of the box, and that's what I'm going to talk about today, this free market healthcare movement that's kind of started out naturally in Wisconsin based on kind of some things I did at Merrill Steel. We ended up transforming our health plan. So we ended up transforming our health plan where we saved over $5 million from the previous trend. We increased accessibility of care. We increased quality of care big time. The employees and their families loved it, and we also made the plan sustainable, which it was not. So what we were lacking was a medical strategy. We had the self-funding part, that's how you fund your plan, but how about your spend, right? If you're just blindly spending, you're never gonna do well. And so that became kind of known. We were the DPC that we partnered with. We were their first employer. 5 years later, they had 37 employers. They were just spreading across central Wisconsin. And so that's what kind of almost unintentionally started this movement. My scope at the beginning was the company, right? We have a company issue. Today, Merrill Steel is on their 8th year of no premium increases with around $40 a month for single and $160 a month for family. And you can be free after that. So that's what this free market healthcare approach can do. So I won't get into the details of how we did that, but we'll talk about the free market tenants. So I'm gonna jump back here. So if you're curious, right, DPCs can work with people that walk in without insurance. You can also work with typically self-funded employers, even fully insured employers if they want to add it on and kind of be outside the plan. But it's a big deal, right? It's around half nationally of the people covered in America are covered by self-funded employer health plans, and besides the government side, and then, 50% of Americans are covered by employer plans, but 67% are self-funded plans. So just to know that the market's there. This DPC that we started with, they tried the community thing. They were even trying insurance. They were about to go bankrupt after 3 years, and then they switched over and went with employers. Now some do both. I think Innovia does both. You allow, no, not anymore, just employers? Okay, so you have to pick your path, but they say if you've seen one DPC, you've seen one DPC. All right, so this is maybe my favorite slide. It's a little busy, but this is the Wisconsin movement, if you will, right? So my scope was the company, then it transitioned to the state, and so as I led that story at Merrill Steel, it got noticed. We won awards, and then I left Merrill Steel. And for 2.5 years, I co-founded this company called Self-Fund Health. We took the plan that worked so well, employer design plan, and then we've been carrying it to, we're a health plan, not a broker. We work through advisors throughout the state. So we're growing as fast as we can keep up. We're at 2.5 years in, we're at 13 employees, hiring as fast as we can, about 20 employers, maybe gonna double in the next 6 months. So just that's the demand for this. Here are some of the headlines. So one of my favorites, so the first DPC that I know of in Wisconsin was around 2010. There are a couple bigger ones now that started in roughly 12 that are still going. And in 2020, a Madison publication came out that said that there are 15 DPCs in Wisconsin. Today we have 128, just 4 years later. That's how fast the doctors are starting clinics. So pretty cool, huh? And then we say DPC, direct primary care, taking out kind of the insurance games and the added cost but little value, right? Direct buyer and seller. Buyer are the employers and employees. Sellers are those providing the healthcare. As someone said earlier, there's a big difference between buying healthcare and buying insurance. So we're taking out the non-value stuff. But DSC, so that's important for employer as well, direct specialty care. That's where you're going to refer to. If you have to refer back because of the network is a guise for a monopoly, right? We don't have a network for anything else we buy. But if you have to refer straight back to the hospital, okay, fine, you have to do what you have to do. They have to be covered. But then that's all the expensive care, and the employer may not save. This year's claims are next year's premium increase for the employers. We have to manage the plan cost and what the member pays. They've been trained to look at that card in their wallet and say, well, I'm covered. Who cares what the cost is? That doesn't serve them well when they get to next year's enrollment meeting. So we're seeing this massive explosion of DSCs in Wisconsin. When we were at Merrill Steel, there's a semi that drives around for an MRI and goes to the hospitals and the clinics owned by the hospitals. We ended up bringing that same truck to our facility, to our clinic. And we could get that MRI for $600. So it'd pull right up, put its stairs down. If that same truck drove to the hospital, it was $6,000, 15 minutes away. And the truck's still charging us $600. So is that value for our money? Where's the rest of that money going, right? Now we have brick and mortar. So this has all happened. If you go back 3 years, only 3 of those bullets are there for those DSCs. So when you see infusion, imaging, just some examples, surgery, there's also actually just got the announcement yesterday, there's going to be an infusion center in Alaska, it's called. So we add one more bullet to that. I can't even hardly keep up with them, which is great, right? So we have DPC referring to DSC. That's a big win for the patient, big win for the health plan. We had in Madison, you see over here, SSM is a hospital system. All of the orthopedic surgeons left, something like 18. And they all left. I think there's 3, I don't know if they went back, but 3 are not with them, but they're starting their own surgery center. These are kind of big headlines, right? They shut down like the whole department. They just left. They just said, this isn't a win-win for us. And that's what we look for, right? When we say don't feed the beast, the book, it's not a specific person or organization, but the beast is someone who breaks the golden rule intentionally and regularly, right? It's someone who is out, puts finances ahead of people. Both are important, but looks at only the finances and the money and the profit side. And ultimately, it's the beast is someone who wants a win for him or herself and then a lose for, right? The industrial complex has a win, and then the buyer has a lose. Well, that's not sustainable. Why would they even want that? A win-lose is never sustainable. So we say, well, someday they'll fix it, right? Well, here's an interesting thing. It's not broken for them. They're doing quite well. So they're never going to fix it. So the solution, this free market healthcare, so we started building this new system next to the old system, this new system of DPC plus DSC. And now we give, and like in our health plan, I'll show you a picture quick, but they can go to the old stuff and pay their old high deductible, or they can go to the new stuff, and the new stuff's all free because we know the price and it's affordable. It's like 1/5 of the cost. And then we even have so we say, well, we can interrupt, if you will, 70 to 80% of the care. We have micro hospitals popping up in Wisconsin. We have one open in Green Bay, and we have one starting in Milwaukee soon. How cool is that? So, right, so we still need the hospital systems, but that percentage is shrinking. There will be a day, maybe in the near future, that we won't need the hospitals. Now, we're not against anyone. We're actually, the BUCAs, I think, are the common enemy in the middle, if you will. We want the hospitals to come over and say, yeah, we'll bundle, we'll work with you. We're not against anyone. We're just we want to shop for value, and we want to find fair prices and high-quality healthcare. So yeah, lots of cool stuff. So I'll go fairly quickly just based on time here, but this was a chart I made from an employer's lens. It's the distinction that in commercial healthcare, what we call commercial healthcare, the only payer is the employer, 80% roughly, employee, 20%. All the money comes from there. So all this money being passed around, the arrows on top represent the money the employer is aware of. The arrows under the table represent the money the employer is not aware of. That's a lot of money flowing around, right? So if you're spending money, don't you want to know where that money's going and if it's value or if it's just padding pockets? And so we talk about the notion of compensation alignment. So we look at forward-thinking advisors will align their compensation so they're not rewarded when the plan gets worse. That is the norm right now. So we want the advisor to not be rewarded as our plan unravels. Then they're right, and the same with insurance. They want the price to go up. They get to keep, according to ACA, medical loss ratio, 15% of the premiums. Well, what do you think they want the premiums to do? 15% of a bigger number is better than 15% of a smaller number. And of course, the seller, the true seller, the hospital or anyone providing the care, wants the costs go up. So this whole side is rewarded when the costs go up, and this side's getting run over by a truck. But we need a win-win. And so that's what that chart kind of brings out. All right, so one of the things to recognize is that healthcare is off the radar for most companies. I tell a story in the book where I had supported the custodial team. We ended up buying a vacuum, but I went through that purchasing process, right? Maybe you've seen 3 quotes. This is like a $400 vacuum. We made the decision really fast. We just want to get the same one that broke. But I find myself for hours filling out this paperwork, and then I realized that morning that I'd signed our healthcare stop-loss insurance. So here I am going through hours of work for $400 purchase, but I signed our stop-loss for $700,000 that morning, and all I needed was a nod from the CFO. Like, wait a minute here. Shouldn't there be an approval for that? I can just sign for $700,000, you must really trust me, right? It's just off the radar. It's viewed as a benefit. So that was a wake-up call for me. And then if you're familiar, I'm a car guy, but the automotive industry is kind of an example of this free market. Why do we believe free market is the solution? Because it's about options, it's about choices. Because if we go to a restaurant and it's not so good, the cost is higher, the food's not so great, or the service, we may go one more time and give them a chance, but we don't go back. they're forced to improve or they're not around. Well, the healthcare industry is monopolized. If you're in network, there's no incentive to even worry about getting better because the person has to go back. We don't have to share prices. We don't have to have good prices. We can get you in 3 to 6 months, all these things that are kind of poor service. And so a free market opens that up and says, so in the 70s, the auto industry, like what used to be the big three, had like 80+% of market share. And it wasn't even as bad as healthcare. They shared the prices and so forth, but they knew they would get their sales. I ran into this guy at Toyota, and he used to work in the 70s at GM, and he said 50% of the cars coming off the line would start. These are brand new cars. Usually they were missing parts. It wasn't that they were broken per se, but they just pushed the line. And so they'd be fixed later, but they didn't have to improve their quality. Well, Toyota in the 80s came in, Nissan in Smyrna, Toyota in Georgetown, Kentucky. I worked at that Georgetown, Kentucky plant, their flagship, 8,000 people, 3,000 cars every 24 hours that would run 300,000 miles plus. Honda in Marysville, Ohio, it forced the former big three, Toyota's now number one, it forced them to improve or they wouldn't be around. So now if we look at the car market, right, it's much better. We see all these new ones come in. It's better for the consumer and they're actually doing better. They're building better cars. So that's kind of this one good analogy of this free market approach. This was a picture that's in the book that I used at Merrill Steel, and this explains like how we do our plan. We're a health plan, but this is a best practice. The dirt road is meant to be less traveled, but members can go to the left on Monday. The left means they pay their old school deductible, co-insurance, max out of pocket. And that typically is the hospitals. I don't like the category, but that's just the way it is today. 3 years from now, hopefully we have a hospital on this side, and right? It's really about just free market shopping, but where's the value? But they can go either side. But if they go to the right side, we call it the paved road, it's all free. The DPC can refer to that side. That's a smooth referral. Patients listen to the white coat, no matter where that white coat is, right? If it's in the hospital or DPC. So it's important to have a smooth referral. But if they find out and they learn that the quality is good on the right side, actually better in my opinion, then they'll go there. And that's how we get the members to do this. So this would be a picture of the plan design. Of course, we bring back primary care like you're doing the way it was 20 or 30 years ago. You can actually talk to your physician. You can reach out outside the visit. You can get chronic condition management, get true care, not that 7-minute referral pinball machine that is happening in many places. So here's a short video. One of the chapters in the book is about, and I think this applies to all of us, but it's called Trustworthy Partners. One of the things I realized when I was at Merrill Steel, I was like trying to drag all my partners along for 2 years. I'm like, let's go. We got free market is the answer. Let's go. I need your help. I need you to be strategic. And I couldn't get them to come along, and I'm getting old. I'm like, I don't have the energy. I'm paying you. I don't have to pull all this out. And so I did a compensation request. This was even before the CAA of 21 came out, the law that says you can legally now request it. They have to give it. So I requested it, and I realized that they were making more from the insurance side than they were from me. So I realized who they're working for, right? And not that they had bad motives. They were good people. But they were just in this system that was rewarding them to not come with me. And so I ended up switching all of my partners, every one of them, because I needed trustworthy partners. It'd be like saying we have a BUCA contract, but yeah, they sneak all this stuff in there that's to their favor. Well, why would I want to pay a lawyer $300 an hour or more to go through a contract with a partner that's already sneaking stuff in the contract? Why would I even want to work with that person? Why don't I just work with someone who gives me a really simple contract who's on my side? So this notion of we shouldn't even waste our time hiring lawyers to review those contracts, not to say we shouldn't review contracts, but we should have people that write contracts that we actually trust. And it can save us a whole lot of time later when I work with people that I can trust. And so we'll see if this plays. But I'm traveling all over 25 cities now in the last 12 months. The book is spreading all over. It's helping doctors, it's helping advisors, it's helping employers, about 5,000 in the first year. I didn't see that coming. But this is from Wichita. I was there in February, I think. Anybody ever seen a trust fall? What's called a trust fall? Anybody ever done a trust fall? Okay. All right, so here's an example there.
Fall, and it'll be an exercise in building trust between one another. So Harrison, if you don't mind going first, step up here on this chair and close your eyes. All right, and then everybody fill in, and we're gonna ask you to fall, and then they will catch you. So you have to trust us. So I'm gonna count to 3, just relax and fall, okay? 1, 2, 3. No, wait, no!
Okay. I would bet he probably never does a trust fall again. This trust is probably broken. Trust is easy to lose, hard to win, right? All right. So let me just close. I'd like to read just the last page of the book, but let me close by just thanking you for your courage, your bravery, for your heart. I've always been big on purpose. I used to work in manufacturing, as I mentioned. I went up to a person that was working in manufacturing. This was a snowblower plant we made 1,000 a day, and he'd been there like 15 years, and he's bending this rod, and I went up to him and I said, "What's that rod for?" He said, "I don't know." So, think about purpose, right? And I need to know. I walked over, it was the chute turn, you cranked for the chute. But so you go into work and he's a great employee, loyal and there, but just bending a rod all day like that, I don't know, that's not enough purpose. And I think maybe that's one of the trends, right? I ask questions, why all the time? Why do we board the front of the plane first and not the back? I don't know. The Delta people don't have an answer for that either. I don't understand. So we should just ask these questions. And right, so you probably are here because maybe you felt like you were a cog in a big money-making machine and you weren't able to practice medicine and healthcare like you dreamed of, right? So, but you've shown the bravery and the courage. So I just want to thank you for that because that's really important. Some people maybe can tolerate that their whole career. I'm not one of those folks, but I'm going to close with this. So it's called The Future of American Healthcare, and it's really based on us. This is by no means automatic. But this is what we're doing in Wisconsin. Many other states are very active too. Texas, Oklahoma, many others, Florida. But here was my message at the very end. The future of healthcare is transparent. The future of healthcare is affordable. The future of healthcare is accessible. The future of healthcare is sustainable. The future of healthcare is understandable. The future of healthcare is relationship-oriented. The future of healthcare is to shop effectively. The future of healthcare is to provide only treatment that is necessary. The future of healthcare is to treat root causes, not just symptoms. The future of healthcare is employers taking fiduciary ownership of their health plans. The future of healthcare doesn't feed the beast who is oppressive and self-serving. The future of healthcare is a positive-sum, win-win outcome for all. The future of healthcare is much brighter, and the future of healthcare is in your hands. Thanks for your time today. I appreciate it.